Treatment of the axilla in breast carcinoma plays a crucial role in staging, determining prognosis, and guiding systemic therapy. It involves a multidisciplinary approach and varies based on the stage of cancer, lymph node involvement, and patient-specific factors. Below is a detailed explanation of the treatment strategies for axilla in breast carcinoma. 1. Axillary staging. Axillary lymph node status is one of the most critical prognostic factors in breast cancer. Staging typically involves A. Sentinel lymph node biopsy, SLNB, indication, early stage breast cancer with clinically node-negative axilla. Procedure. A dye, radioactive tracer, or blue dye is injected to identify the first lymph node, sentinel node draining the tumor. This node is surgically removed and analyzed for cancer cells. Outcomes. If negative, no further axillary surgery is needed. If positive, further management depends on tumor burden in the sentinel node and additional patient factors. HAR B, axillary lymph node dissection, ALND. Indication, clinically positive nodes confirmed by biopsy. Positive SLNB with significant tumor burden or specific scenarios. Procedure, removal of level 1 and 2 lymph nodes. Complications, lymphedema, shoulder dysfunction, and sensory loss. 2. Definitive treatment of the axilla. Treatment depends on the extent of nodal involvement, systemic therapy plans, and patient factors. A. Clinically node-negative, CN neuro patients. SLNB is the standard of care. If SLNB is negative, no further axillary surgery is required. If SLNB shows minimal disease, e.g., micrometastasis or 1 to 2 positive nodes, patients may be managed with radiation therapy instead of ALND in select cases, e.g., 0011 trial criteria. B. Clinically node-positive CN1 patients, preoperative systemic therapy, neoadjuvant therapy for downstaging axillary disease. Post-therapy assessment determines further axillary treatment. If disease persists post-neoadjuvant therapy, ALND is often performed. If nodes are negative post-neoadjuvant therapy, some patients can avoid ALND based on imaging and SLNB. C. Advanced nodal disease, CN2, CN3. ALND is typically performed after neoadjuvant therapy. Postoperative radiation therapy is usually indicated. 3. Radiation therapy for axilla. Axillary radiation is an alternative to ALND in certain cases, e.g. 0011 Amaros trial. Indications: positive SLNB with limited nodal involvement. Residual nodal disease after neoadjuvant therapy. Advanced nodal disease N2, N3. 4. Systemic therapy considerations. Chemotherapy, endocrine therapy, or HER2-directed therapy is guided by the primary tumor and nodal status. Neoadjuvant chemotherapy can downstage axillary disease, potentially reducing the extent of surgery required. 5. Minimizing morbidity. Advances in axillary management aim to reduce treatment-related morbidity, avoidance of ALN when possible based on SLNB and systemic therapy response. Axillary radiation, preferred over surgery in select patients to decrease lymphedema risk. Rehabilitation and physiotherapy, for patients undergoing ALND or radiation to improve shoulder mobility and reduce lymphedema risk. NASHAR 6. Key trials and guidelines. ISOG Z0011 trial showed that SLNB alone was sufficient for selected patients with 1-2 positive sentinel nodes. Amaros trial compared ALND and axillary radiation for positive sentinel nodes, showing comparable outcomes with reduced morbidity in the radiation group. NSAB B51 and Alliance A01122 trials, ongoing studies refining axillary management post-neoadjuvant therapy. In summary, the treatment of the axilla in breast carcinoma involves a tailored approach focusing on accurate staging, disease burden, and minimizing complications while ensuring oncologic safety. Sentinel node biopsy is the cornerstone for early disease, while ALND or radiation may be required for more advanced cases. Multidisciplinary input and patient preferences guide decision-making.